I will go ahead and get started. So, my name is Megan. If you haven't watched any of these before, I am the co-founder and president of Recurrent Pregnancy Loss Association. RPLA is a nonprofit organization for the community of families who have been impacted by recurrent pregnancy loss. And we put out information to try to help educate the community, help you navigate your journey with this. We run a monthly free virtual support program if you're looking to connect with other people that are going through this really unpleasant experience. And we also do a lot to try to advance science and support research into understanding why this happens and hopefully how it can be prevented in the future. So that's a little bit about us. More importantly, I am here today talking to Lee Hornberger. Katie is a certified genetic counselor who specializes in reproductive medicine. She's worked for one of the most well-known IVF clinics in the US, as well as genetic testing laboratory that offers fertility-related genetic testing. And right now she's working for Seattle Sperm Bank. Katie counsels patients on the benefits and risks of genetic testing and how genetic test results may impact patient treatment options. Katie is unfortunately also part of our own community. After nearly 3 years of unexplained recurrent miscarriages that she experienced herself, she started a YouTube channel, which I will put the link to in the post for this video, to support people that are going through fertility treatments and miscarriages. And she uses that YouTube platform as well as her social accounts to share medically accurate information about genetics and fertility testing. So, and happy to share though that you have welcomed a daughter, so
Yes.
you have a somewhat happy ending to this story. Well, a happy ending, but not necessarily a happy ending to the story. The pain doesn't go away. But I'm so excited to have you here today. So thank you so much, Katie.
Yeah, thank you so much for having me.
Yeah, and maybe let me I read your bio, which is so impressive, but maybe if you could start by just telling us a little about yourself. How did you decide to be a genetic counselor? What exactly is a certified genetic counselor? Why did you decide to focus in reproductive medicine? Tell us a little bit about your story.
Yeah, absolutely. So genetic counseling is a bit of a niche career in healthcare, but it was one I was really interested in because I thought maybe being a counselor of some sort would be a good fit for me. And then the idea of fitting in my love for genetics into one career was amazing when I first learned about it. So to become a certified genetic counselor, you complete your undergrad, usually in something science related like genetics or biology, but it doesn't have to be, as long as you take some prereqs like genetics and biology, chemistry, and then you go to a 2-year master's program. In genetic counseling, where the classes are essentially your sciences, your genetics, and then psychosocial and counseling classes and clinical rotations. And most genetic counselors practice in prenatal settings, maybe helping people who are already pregnant review any genetic test results or abnormal ultrasounds that look like they could be associated with the genetic syndrome. Cancer, if you have a family member who's had cancer, especially cancer under the age of 50, they've probably seen a genetic counselor and been offered genetic testing to figure out if there's a hereditary component. And then a good number of genetic counselors practice in pediatrics. So once a child is diagnosed with a genetic syndrome, or on that hunt to find a genetic syndrome, they might see a genetic counselor. Reproductive genetic counselors, it's a really small subset of us. It's about 3% of us genetic counselors that are in that space. But we definitely need more because there's a lot about genetics when you think about fertility and fertility treatment, and certainly RPL or recurrent pregnancy loss too. And for myself, I was interested in getting into the space of reproductive genetic counseling because I am one of those people who wanted to have a kid since I was like 4 myself. I couldn't wait to build my family. So I couldn't imagine anything better than helping people who were struggling to build their family do that. So it's just been a great home for me, and I can't imagine ever leaving it. I've been working in reproductive medicine since I graduated, and I think I probably always will be.
Awesome. Thank you so much. Well, we're Thank you for working in this space. Tell me a little bit more about like how does that work? What is the relationship? Someone goes to a fertility clinic, or even I don't know if there are genetic counselors that are working with MFMs or OBs, but what is the relationship between a certified genetic counselor and the doctor?
Mm-hmm. Yeah, so most OB offices and most IVF clinics don't have a genetic counselor in-house. They may not even use one. Some might refer to one who works through telehealth or who works at maybe like a bigger practice at a different hospital, and you might have to go travel there to see them, or meet with them on the phone or through telehealth. But for those who do, like you mentioned in my intro, I worked for a fertility clinic. It is crazy for me to try and wrap my mind around all of the fertility clinics who don't have one in-house, because there's a lot that we can do for your reproductive endocrinologist, and a lot of things that sometimes can get missed when a reproductive endocrinologist has a lot of other things to do, like managing your treatment, that can fall beyond their scope or just take a lot of time to explain. Mm-hmm. And what genetic counselors can do along with the fertility center or with your OB is oftentimes take a close look at your family history and assess it to see, is there anything that suggests there could be a genetic disease in your family? And do you want to think about that before you start building your family, while you're building your family, or is it a worry you're going to table for later? Yeah. And then they can also look at your family tree and say, oh, is there any concern that there could be a hereditary cause for infertility or for recurrent losses? Then they can help you with ordering and consulting you and explaining all of the genetic test options that are on the table. And we'll talk about each of those today, but they can oftentimes spend more time than a doctor can with you, because our whole job, the point is to, consent, offer pre-test and post-test counseling for any type of genetic test that's available. And that might make it kind of either help you understand what's going on, help you get an answer for what has happened, and help guide treatment in the future.
No, that's really helpful to understand. Thank you. Mm-hmm. And so as we get into this, this is a hugely broad topic. So I was looking at our questions and I'm like, oh my God, we're going to need multiple conversations. But maybe if we could just start with, for a lot of us, talking about like understanding and even talking about this feels a little bit like French. So I know that there are a lot of genetic tests and a lot of kind of categories of genetic tests that someone might go through as they are starting the trying to conceive process or working through a diagnosis of recurrent pregnancy loss. So maybe if you can just briefly talk about sort of the buckets of tests that might fall into, and then we can get a little bit more specific into each one of those.
Yeah, absolutely. So I kind of think of 4 hallmark genetic test options that might become available to you if you're somebody who's listening to this live right now. The first is really general. It's carrier screening. It's actually something that should be available to anybody who wants to conceive now or in the future. And I bring this one up because it's very widely available. If you talk to friends who are, trying to build their family, usually OBs offer it, maybe during pregnancy, or ideally preconception before you would start trying. But the thing about it is, a lot of people think when they get their results back, oh, this is great news. This means I should be able to conceive no problem because nothing alarming comes up. And that's not the case. The goal of carrier screening is really to say, does this egg source and sperm source together have an increased risk for a childhood disease that could be significant, that could be lethal? It doesn't tell us anything about recurrent miscarriage. So that's carrier screening. That's one. Another is karyotype. And carrier screening and karyotype, very easy to get them confused because those two names sound so similar, but they are completely different, tell you totally different things. Carrier screening is looking for a number of these diseases where you're reading individual genes and you're just looking for little mutations or misspellings. And then if I rewind you back to your last biology class, we each, as a human, most of us, I should say, have 46 chromosomes. And there's hundreds of genes on each of our chromosomes. So carrier screening is looking for little misspellings in these genes. Karyotype, this other type of test that's also just a blood test, it's going to count up the number of chromosomes that you have. It's offered to typically, again, both the egg source and the sperm source. It might be indicated, especially if you're somebody with recurrent miscarriages. And what that's doing is just getting a general picture of your chromosomes. Do you have 46, and are they arranged the way that we want them or expect them to be arranged? Are they arranged typically? So we've got carrier screening and karyotype, both which just require a blood sample from the egg source or sperm source. The next one that comes up, especially for us again who are attending this live, is testing on a miscarriage, testing on miscarriage tissue. Yeah. That's often referred to as POC, or products of conception testing. And that type of testing can be done to figure out, was there a genetic difference? Was there a genetic abnormality that probably caused this miscarriage? And it can help somebody get an answer for why a pregnancy loss might have happened, and maybe help guide treatment as to what might be a good next step depending on what you see. And then the final genetic test that comes up quite a bit is genetic testing that you can do on embryos. So if you're somebody who's considering or who has done in vitro fertilization or an IVF cycle, a small sample of the embryos created in the lab can be taken, shipped off to a lab that's doing, like, specializes in this type of genetic testing. And that sample can be used to count the number of chromosomes in the embryo, and then to help patients find the best embryo to transfer. So those are the 4 tests.
No, thank you so much. That's really, I mean, and this is why it can be so confusing and why it's so important to have somebody that's expert in this help walk through it. So you talked about carrier screening, and that it's a little bit easier to, or it's easy to get confused with karyotype testing. And those both require a blood test. But let's then talk a little bit about the carrier screening. You mentioned it at the beginning, but really, like, who should have this? And if something comes back that you are a carrier for something, what do you do about it? Like, what's the process for that, and where would that most likely be managed?
Yeah, absolutely. So carrier screening is for everyone, any ethnicity, any mode of conception, whether you're using a sperm donor, an egg donor, whether you're planning to get pregnant with a partner, it is for all of us. And just because it's for all of us doesn't mean everyone might decide they want to do it. Okay. There are some people who are more information seeking than others. So really what I'd say, if I was counseling somebody, I would say, if you're somebody who would want to know this information up front, you'd want to know, okay, together, me and my partner, or me and this sperm donor that I'm interested in, we have a significantly increased risk to have a child with spinal muscular atrophy, a fatal condition. I would probably say, I want to know what my alternative options are. Yeah. Or I want to think about testing my pregnancy during the pregnancy and deciding what to do at that point. So the whole point is to have this information up front, pre-conception, so you can say, do me and my partner, do me and my sperm source have an increased risk for one of these diseases? And if so, what should we do? And with these tests these days, they oftentimes include hundreds of conditions. The panel that we use at Seattle Sperm Bank, we're testing our donors for 502 different diseases. So you're testing for a lot, you'll find a lot. Most sperm donors and most of us will come back a carrier of 2, 3, maybe 4 different diseases when you go looking for that many. And that's normal. When you're a carrier, it doesn't affect your health for the vast majority of conditions. All it means is that if your other gamete source, your sperm source, is also a carrier of the same condition, you've got a big increased risk to have a baby with that disease. So the goal is just to screen for these diseases. It unfortunately does not tell us anything about pregnancy loss. So sometimes I'll hear patients who will say, oh, well, after my second loss, I decided to do the carrier screening. My OB recommended it to me. And good news, I was completely negative. I don't carry anything. So that's good news for the next pregnancy. And I have to say, unfortunately, that really doesn't tell us anything about risk for miscarriage, because we don't really know single gene changes that cause an increased risk for miscarriage. So it's a good test to do to give you options in case you and your partner are at an increased risk to have a baby who could be affected with one of these really impactful diseases. But it's not going to tell us anything about risk for miscarriage or chances for a healthy live-born baby in a next conception.
Yeah, no, that's really important. It tells you more about the risk to, like, what might be at risk for the child when the child's born. It doesn't really tell you anything about whether or not the pregnancy is going to be able to, like, successfully. That makes a lot of sense. So then to go to the other one, that's just the blood test, the karyotype testing. Tell us, a little bit more about this one and what those results are telling you, and whether, who is this test appropriate for? Should everybody that's experienced multiple miscarriages be having this test done, or when would you recommend it? Who would you recommend it for?
Mm-hmm. So karyotype, the other name for this test is chromosome analysis, and you'll hear those two names used synonymously. So karyotype or chromosome analysis. The thing about this test is it's offered much less frequently than something like carrier screening, because not many of us walking around the planet have a chromosome difference. It's pretty rare. Where most of us are carriers of a disease, most of us have the typical 46 chromosomes arranged in a standard way.
Yeah.
So usually this is something that either an OB or an MFM or a reproductive endocrinologist would offer you when they hear that you've had recurrent miscarriages. Whether it be 2, 3, or more, it's typically offered at that point. And like, for example, the American Society of Reproductive Medicine, they recommend a karyotype to both the egg source and the sperm source if you've experienced recurrent losses. So I hear it getting missed often. And it's one of those things where I'd say, if you've had definitely 3 or more losses, you definitely want to be asking your doctor, hey, is it time to do a karyotype? Because you can get a very clear answer for the cause of miscarriages if you find out that you or your partner have a chromosome difference. And then there's some pretty specific things you can do going forward on top of having an answer. Now, I will say for myself, I waited till I think my 4th loss even to do a karyotype, because it is one of the most expensive of all of the diagnostic tests, and it has a really low hit rate. Only about 2 to 4% of couples with recurrent pregnancy loss will be found to have a chromosome imbalance or a chromosome structural change that was probably causing those losses. So that hit rate's pretty low. And for me, it felt low enough to me that I'm like, I'm going to wait a little bit. I'm going to hold off because it's a pretty expensive test. Sometimes you can see, like, if you're somebody who's had a family history of someone else who's had recurrent miscarriages, that would be another sign, a kind of a red flag that, there could be something in the family.
Yeah.
But it's not always a guarantee. I've definitely seen many patients who have recurrent pregnancy loss just with them and their partner, nobody else in a big family, and they're found to have one of these chromosome changes that probably explains their recurrent loss.
Okay. So, and you said, so this is something that, as we said, it's in the ASRM recommended workup. We are talking about a small percentage here. So like 2 to 5% probably of the population of people that have experienced recurrent loss, this will be the cause. And then you also said, like, if that's continuing to happen, maybe ask your doctor to do this test if they haven't already. Is it one test, or are there actually different types of tests, and do you recommend one over the other?
So for karyotype or chromosome analysis, this is actually probably of all of them the only one that's very straightforward. It's all the same. Cool. You can get it done through LabCorp or Quest or any other lab, and it's all the same. All we're doing, it's a technology that's been around for decades, is counting up the chromosomes, looking at the bands and the banding pattern on the chromosomes to make sure they look typical. I'd say one of the other common questions I get about karyotyping is, well, how could I have a chromosome difference if I physically don't look different, if I don't have intellectual disability? And the thing is, it's possible. People who have chromosome rearrangements, all of the genetic material is there. Your DNA is all present. It's just arranged differently for those people. So it doesn't cause any health problems, any developmental delay or intellectual disability. All it causes, if you have a structural change to your chromosomes, is an increased risk for miscarriage and infertility. Yeah. And for some people, an increased risk to have babies who are born with physical differences or intellectual disability.
And so, I mean, I guess the next question would be, so I do this, I find out that I am one of those people that has like a chromosomal rearrangement. Now what? What's the next step for couples that will have gone through this and gotten a positive result? Yeah, absolutely. So for those 2 to 5% of couples who get an answer, they find out that them or their partner does have a structural change, like an inversion or a translocation. They have a few different options. I think the biggest thing here is now knowledge is power. Now we know that there's an increased risk for an embryo or for a pregnancy that gets the wrong number of chromosomes and results in a miscarriage or results in a baby who has
a physical difference. So you can do a few different things about it. Some people choose to do nothing. Some people say, okay, now we know, and we're going to understand going forward, we do have a higher risk of miscarriage than other couples, and we're going to do some early testing if we do get pregnant. We're going to test that pregnancy, and we're going to confirm whether the chromosomes are typical or atypical and go from there.
Yep.
Some people will say, okay, now we know that it is the egg source or the sperm source that has this chromosome difference, and we're going to swap out that egg source or sperm source with a donor.
Okay.
And we're going to be able to, essentially eliminate that structural change problem.
Yep.
And then the final option that some people will proceed with that's a little bit controversial is you can go the route of in vitro fertilization and test your embryos for chromosome errors. Yep. With PGTA or preimplantation genetic testing for aneuploidy to find the embryos that have inherited the typical number of chromosomes and transfer only those.
Yeah.
Now, for people who have structural changes and don't have difficulty conceiving, they don't have infertility per se, most studies show that there's not a huge increased chance of success even when you go that route of IVF and genetic testing, because you can still get pregnant on your own. And the cost of IVF is a lot. So if you think about kind of the risk and reward there, it's not always just a slam dunk to throw in IVF with genetic testing, but that is another option. And a lot of people go that route.
No, that's helpful. And I think it's important. I'm just I think sometimes there's a misconception. Like if you do end up having a balanced translocation or something like that, like it is still possible to conceive a pregnancy that has no problem and will continue to a live birth. It's not like, oh, I have this, so I'm going to lose every subsequent pregnancy. It's just your risk is higher in that case.
Yeah, absolutely.
Yeah, no, that's helpful. So I know you mentioned we brought up IVF, and I want to spend a good portion of time talking about that piece of it because I think there are a lot of questions there. But before that, let's talk a little bit about testing miscarriage tissue. And for anybody that's watching, we also did an Instagram live last year just on this topic, which is still on our account, so you can watch that live. But Katie, what I want to understand more from you is so what is this looking at? When somebody gets back the results of that, what is it actually telling them when they get one of these tests? And how is it conducted different than a blood test? Yeah,
absolutely. So with products of conception testing or POC testing, the testing you can do on a loss, I do want to mention that there's a few different ways it can happen. So if you have a pregnancy loss at home or out and about wherever it unfortunately may be that it occurs, you can collect tissue from that loss wherever you are. You can keep it in the refrigerator and you can send that tissue off to a lab with the help of your doctor, putting in an order and doing that testing. The more common way I see most patients come to this testing is that they have, a D&C or a D&E in their doctor's office, and the doctor is able to collect the tissue from the pregnancy loss and send it off to a lab. But both are completely fine ways to collect the tissue and to send that off and to do the testing. So
it's not though, to my understanding, this is something that you need to ask for, right? It's not like if you have a DNC or a D&E procedure, this isn't going to automatically be done. It needs to be requested.
Oh, that's a great point. It needs to be requested. Yes. An astute doctor, or if you're to the point of seeing a reproductive endocrinologist and they know your history of recurrent miscarriages, should definitely be offering it to you. But no, yes, if you're somebody who wants answers and you're interested in this test, it should be one of the things you're asking about and asking for is this POC testing. Okay. And then with the POC testing, whether you send in the sample yourself or your doctor sends it in after a DNC procedure, results usually take a week or two. And what you'll typically find from the results is one of three things come back. Either you find out that the tissue that was sent in is chromosomally normal. Okay. And that's what's happened when I have sent in the testing. I've sent it in 3 times. I've gotten an inconclusive twice and a normal once. So the pregnancy was chromosomally normal or the baby was chromosomally normal. Essentially, that just means we don't have an answer for why this happened. And also, unfortunately, you're probably never going to get an answer because that's really one of the only things we can do for each individual loss to try and understand why that loss happened. The second possibility is you get a chromosome abnormality or an aneuploidy. You find out, oh, well, this pregnancy, it had 3 copies of chromosome 16. It had trisomy 16. So it's not compatible with life. Unfortunately, that baby was never going to make it to term, because when you have all of those extra genes, a baby stops developing very early on. So you might get an answer like that and be able to say, okay, it was aneuploidy. This chromosome imbalance explains why I had that loss.
Yeah.
And then the third possibility is an inconclusive result. This can happen for a variety of reasons. It can certainly happen when, if you have a very early loss, like I've had some early losses at home, I'm talking like 6 weeks, 7 weeks, and naturally miscarried and tried to collect and send in the tissue myself. Depending on what tissue you collect, even if you think you've gotten it all, sometimes there just isn't enough, or the quality is not high enough to run the testing, and the lab has to report out it's inconclusive. We don't know, So sometimes it can give you a bit of an answer. Other times it's you just are kind of in the same spot when you get an inconclusive, or even when you get a normal result.
Yeah. No, that makes sense. So I have a couple questions. So first, like, if somebody's going to request, what specifically should they ask for? Because this one, I know there are some like different options. So what do you recommend people ask their doctor for if they would like to test their miscarriage tissue and get those answers?
There are differences, and there are really important differences with the products of conception testing. So there's 2 different types of technology. The old school type is karyotyping. So like we've talked about before, you can make a karyotype on any adult, a child, a baby, a pregnancy, and that's where you're just counting the number of chromosomes and saying, are there 46 chromosomes normally arranged or not? Now, karyotype, there is a huge pitfall when you do that old school technique. And that pitfall is, if you see 46 chromosomes and 2 X's, which means somebody who was assigned female at birth, essentially, you may not know, especially when we're thinking about those very early losses, 6, 7 weeks, you may not know whether you got the person carrying the pregnancy, their tissue, like their lining, or whether you're actually testing fetal tissue. And that means that the result may not be as valuable if you do that karyotyping and you see that the result is 46XX. That could mean it was mom, or it was person carrying the pregnancy, or it was actually a typical female pregnancy.
Yeah.
So what I would always do, what I recommend, is microarray with SNP testing, that type of based products of conception testing. It is better because you get a sample from the person carrying the pregnancy as well, usually just a cheek swab or a spit kit. And then they'll compare some genetic markers from person carrying the pregnancy to the tissue of the loss. And they'll be able to say whether this was DNA from the person carrying the pregnancy and the result is just, it doesn't tell us anything, or whether this actually is a accurate and unique result on the baby or on the pregnancy loss. So the lab I'm not affiliated with, I've never worked for, but I like is Natera's Anora test. I also really like that they have a cash price. So if you don't have great insurance, you can get that testing for $350 cash price, which is great.
Yeah, no, that's really helpful. Thank you. And then I guess, like, and can I just want to clarify. So the karyotyping that somebody would do on their miscarriage tissue, totally different from the testing of the parents, right? So like I do this on my products of conception. It still doesn't answer the other question that we were talking about previously. Okay.
Nope. So you can have an abnormal, most people who have an abnormal pregnancy loss have totally normal chromosomes, doesn't tell you anything about that. You can also be somebody who has chromosomes that are different than typical and goes on to have a normal pregnancy loss too. So yeah, completely separate. You're right.
And then I guess the other question is, so I go through, I test my tissue and I find out it was either a normal pregnancy or that there was something that was abnormal. What as a genetic counselor, like, what do I do next? Like, what's the answer for me?
Yeah. So the thing about products of conception testing is it doesn't necessarily guide treatment super well, because we're sampling, like for somebody like me who's had 5 losses and I've only gotten 1 conclusive result, I don't know what that means for my other 4. And most people don't start testing until they get to their 2nd, 3rd, or 4th loss. So you've just got this one little data point to say, okay, I know 1 out of my 5 was abnormal, or I know 1 out of my 5 was normal. So it's not for me necessarily about guiding treatment as much as having an answer. Like
Yeah.
being able to understand, okay, I know I want to figure out the cause. Now I know at least this was the cause for this. If it's euploid, you're kind of still on your wild goose chase. If it's aneuploid, you think, maybe some of my other losses were abnormal. Maybe I want to do something about that. What would that something be? Maybe you do IVF with genetic testing on your embryos. Maybe if you're somebody who's 35 plus or your egg source is 35 plus, maybe you think about using an egg donor perhaps to try and reduce the risk for chromosome errors. But it's not a slam dunk. It's not diagnostic. Like you have one abnormal POC. That doesn't mean, okay, we've got an easy solution for you. Unfortunately, that's not the case at all. And it never really is with recurrent miscarriage.
You have one abnormal and you're like, oh, my eggs are bad. Not the right conclusion. Yeah.
No.
Yeah. And I mean, is it possible, is it possible that you could have normal tissue, but there still might be something in the genetics of that embryo that was incompatible for life down the road? I mean, might that be something that could cause the loss?
Yeah. I mean, this testing, it only is, again, quantifying chromosomes, and chromosome errors are the biggest cause of miscarriage. We think they probably explain 50 to 60% of miscarriages in general.
Yeah.
But there are other things that are more zoomed in that could cause a baby to pass away really early in life or in utero even, a fetal loss. So there's other things we don't have a good test to look for yet, and we don't understand very well yet either.
Yeah. No, thank you for walking through all of that. It's a tough decision, right? Like, I mean, obviously you've experienced multiple losses, as have I. I didn't actually test any of mine, so, and it's, you think in hindsight, what would I have done? Would I have done anything differently? But in the moment, it's a very complicated decision always.
Oh, and actually, Megan, I should say, while we're talking about that of like, oh, maybe you realize after the fact, after loss, that this maybe would have been an option and you're somebody who's interested in, oftentimes, if you had a DNC and usually pathology is sent on tissue from a DNC, that's pretty standard. I think almost anywhere, regardless of where you have your DNC done, you can call, this requires some major effort and your doctor may or may not do it for you, but you can call the lab that did the pathology, ask if any tissue or any slides, any like paraffin blocks, pretty much any sample from that loss is remaining, which they often keep for years. And depending on the lab, you potentially could send that sample off or authorize for that lab to send it off to a different lab who could run products of conception testing. So it's not a never if the tissue remains somewhere. It just can be harder to get a result from that, the way that sample is processed if it's been stored for a while.
Interesting. I had no idea that was even possible. Learning.
Yeah, I'm digging up an old sample of mine to see if I can qualify for a study. So yeah, those samples are there and they're there to be used. So if you're really, if anyone's really regretting not doing that testing or just didn't know about it, that's one place to go looking.
Awesome. Thank you. Okay, so now let's. I know we're blowing through things really quick, so please, if anybody has questions that we can go deeper, feel free to reach out after this. But I want to make sure we have time to talk about the world of IVF and pre-genetic testing and how it all fits into this conversation of recurrent pregnancy loss. And Katie, before we did this, I was saying like this is such an interesting topic, and people feel a lot of ways about it. And I think even this community feels a lot of ways about it. And some people are really afraid to go to a fertility doctor because they don't want to go in and say, oh, if I go to a fertility doctor, I'm just going to be told I have to do IVF. Mm-hmm. So I want to start by just letting you kind of set the stage from your perspective, from a genetics perspective, when might IVF be a good approach for couples that have gone through multiple miscarriages, and when might it not be as useful of an approach?
Okay, most straightforward patient population that it's appropriate for is somebody who's having trouble conceiving. Maybe your first 2, 3, 4 pregnancies, they were easy. You're getting pregnant the first, second, or third month, but then as things start going on, you aren't getting pregnant. It's taking 5, 6 or more months to conceive. That's when I'd say, okay, now we're thinking more about infertility as well as concern about recurrent miscarriages. Mm-hmm. This is definitely the type of patient where I'd say, you want to consider IVF, especially depending on how old you are. So age is another factor, maternal age or age of the egg source.
Okay.
If you're different papers draw the line in different places, but I'd say if you're 35 plus, definitely 37 plus, that would be when I'd be more willing to consider IVF with genetic testing. The reason is we know that as we age, as egg sources age, our risk to have eggs with chromosome errors increases. So whether or not you know what the cause of your previous losses were, as we age, our risk is all increasing. And doing genetic testing on embryos, finding those chromosomally normal ones could reduce the risk for that one problem, while there might be other undefined or idiopathic causes of loss for your previous losses. So those two populations, I think, are very straightforward. You know, you're having trouble conceiving or you meet the criteria for infertility and you're 35, 37 plus. And then the other thing you could think about too that's a little bit more gray is, do you have a history of pregnancy losses that were tested and found to be chromosomally abnormal? Or a history of babies who've been born with chromosomal losses? Or gains, chromosome changes. So if you're somebody who's happened, and I don't meet these people barely ever, but if you've done like 3 products of conception tests and all 3 came back chromosomally abnormal, I'd say, oh, well, now we can almost assume that there's a major chromosome issue here, and IVF with genetic testing on the embryos could significantly improve your chances. So those are the 3 main groups I think of as, you know, when I might be considering going the IVF route. But I'm very much with you. I was very skeptical of IVF, and it was not something I was interested in my journey, which spanned for me the ages of like 28 to 31. It just wasn't, I had such low hope based on the research I've read and what I've seen in clinic that was going to be a solution for me. So I think it's one of those things, if you're somebody who has like idiopathic or unexplained recurrent pregnancy loss, you don't have a history of chromosome errors that have been identified in your losses or in live-born babies, and you're younger, you're 35 or younger and getting pregnant easily, it's one of those things where we definitely don't have good evidence that it's going to help. Could it work? Yeah, just like conceiving naturally could work next time. But do we have good evidence that it's going to improve your chances for a live-born baby? No, not for the younger patients with unexplained losses.
Yeah, and I listened. That's really helpful to think about, right? So it's like if you're younger, if you've gone through an RPL workup and they've found some other causes, if you're getting pregnant really quickly, I mean, I did go through the IVF process. It is a long process, right? Like when I think about my like time to pregnancy when I was doing it naturally versus like the time to pregnancy going through IVF, I understand that, like, kind of what the papers say. It's like, this might be faster to getting you pregnant, I think. But I also understand for anybody watching that, like, emotional piece of like, well, I'm removing this one variable. That's gotta help. And it's like, I don't know if it actually helps. It's more of a psychological help. So yeah. So tell me, going back to the test, like, how is this performed, and what exactly, because there are different types of pre-genetic testing that can take place in an embryo. So how is it performed? How is it done? What is it looking for?
Yes. So preimplantation genetic testing for aneuploidy, which is like such a long term. We call it PGTA, and you'll also hear it referred to as PGS, preimplantation genetic screening. That's just the older term, but some clinics, some doctors still use that. It's the same thing. The way that it works is that a female patient or the patient who's carrying the eggs would have an egg retrieval. Typically, they go through stimulation, so injections, hormones, a lead up of quite a few appointments, and medications that do have some risks and definitely have some side effects for most people. And the goal of that is to help that patient grow as many follicles and get as many eggs as is healthy and safe out to improve the chances for multiple embryos at the end of the day. So she goes through this process, has an egg retrieval where the eggs are removed, and then in the laboratory, the eggs are combined with a sperm sample. And that sperm is usually just got to get collected with masturbation and then passed off to the embryology department or the embryology lab. A sperm is put into each egg, or maybe a big sample of sperm and eggs are combined together, depending on what fertilization technique a lab likes to use. And then the embryos are cultured for a few days. So usually they're grown in the embryology lab for 5, 6, 7 days or so. And by 5 or 6 days, some of the embryos, not all, a good number of embryos are anticipated to die or arrest as development's occurring, maybe because they had chromosome errors, maybe because we just don't understand that process perfectly.
Yep.
But by the time they reach about 5 or 6 days, they should have 150 cells or so. And that's the time when an embryologist can go in with a little suction pipette and remove about 5 or 6 cells from that embryo. And those cells are labeled and shipped off to a lab, or maybe in-house a laboratory performs testing. Meanwhile, the embryo has to be frozen. We can't grow embryos past 5 or 6 days. So the embryo is frozen, labeled and frozen, and it's waiting for the results. At the laboratory, those cells are broken open, the DNA is collected out of those cells, and a technique is used to count the number of chromosomes that are present and quantify that. And we look for missing chromosomes, extra chromosomes, or to see whether the embryo is expected to have just 46 chromosomes and it's considered normal or euploid. Usually within about 1 to 2 weeks, the doctor will get the results back, and they'll call the patient with the results and let them know, okay, you had X number of embryos that are chromosomally normal, X that were chromosomally abnormal. And unfortunately for some patients, they have an all abnormal cycle, or sometimes you have no embryos that even make it to that testing stage, or you have some inconclusive results or some gray results. And the thing about PGTA is it's hotly debated. It's been a hot topic for a long time, and I feel like it's only getting hotter over time. Mm-hmm. We have lots of questions about it in the field and for patients who are using it too, in terms of the accuracy. Is there a chance for a misdiagnosis? Like, is there a chance you could call an embryo that's normal abnormal and it could be discarded? Mm-hmm. So it's not a perfect test. It's really a quite new technology. When I say quite new, I mean it's been around for like 15 years now, but it's very new compared to other types of genetic tests, and we still have a lot to learn about it.
Yeah. So a couple of the questions that came in about this, and that you kind of just alluded to. But first question is you're taking 5 cells out of this 150 cell roughly embryo. Is there any risk that is going to be damaging to the embryo?
Yeah, that's a good question. So most clinics, like the clinic I used to work at, have data where they would compare, embryos that the patient chose not to do that type. They didn't do any genetic testing. They just needed IVF. So they did IVF and then transferred the embryo without testing, to embryos that have been biopsied, have had those cells removed, shipped away, and then transferred. And they do see differences in success rate most of the time because the chromosomally normal embryos are transferred. Now, the way to think about risks, there is a small risk when you biopsy those cells that it could arrest, the embryo could arrest, could die, it's not available for transfer at that point. Yeah. Or when the embryo is frozen or thawed, it might not be viable. It may have died on that process or during that process, but those risks are small. Most clinics quote somewhere between like a 1 to a 5% risk for an embryo to arrest in one of these processes that are required to do the testing.
Okay.
So we think the risks are quite small. And, what's interesting is you'll see some clinics where almost every patient does PGTA, regardless of their diagnosis, their age. And you'll see other clinics where the vast majority of patients don't do PGTA. So that's kind of what I mean by it being a really hot topic, is even if we understand that risks are probably pretty low, we don't perfectly understand the utility of the testing and how much it improves chances for success.
Okay. So is that when you say some clinics that this is sort of like standard practice for them and other clinics where it's not, what's your take on what's driving that? Is it like doctor preference? Is it, preference from the embryologist or the geneticist? Like who's kind of driving those types of decisions?
I know. Yeah. It all comes down to that we're just still learning about it, and there's not loads of great large prospective studies on success rates with this type of testing and without this type of testing yet. And even for the studies that have been published, they go in both directions. Some show PGTA really improves outcomes, some show they're totally equal, and it's no difference, but it costs money and it means the embryo had to be biopsied. So it really depends on what papers your doctor is reading and believing in. And I see pretty much everything very gray. So I definitely can see both sides.
Yeah.
But it's just one of those areas where we have a lot more to learn. If it were me, I'd probably lean towards doing the testing, but I'd want the result of every single one of my embryos. And for my abnormal embryos, I don't know if I'd be so quick to believe that they truly were abnormal. I might keep those frozen a little longer. Or I might maybe say, I just want to wait. I'm not quite ready to discard until I was done building my family.
And that's actually, we got a question that came in was, you know, this technology is relatively new. It's advancing. Let's say somebody did some pre-genetic testing on their embryos a couple years ago and they're sitting frozen. Is this something that like ought to be repeated? Is that, you know, like what, as technology advances, like what happens next for that person?
Yeah. So it's all going to depend on the lab that did your testing, because most labs, especially the big labs in the US, are all doing the same or using the same type of platform. What's really different, and I think it's unfortunate, this is kind of an insider secret, I don't hear patients knowing about this very often, is that the way that each lab reports the results is different. Okay. So the thing is,
testing, the reporting.
The way that it's reported. Yeah. So like the specific thresholds and cutoffs of when do you call an embryo mosaic in between normal and abnormal versus abnormal? It all differs depending on the lab. So I wouldn't say necessarily there's ever a need, you know, unless the embryos are like 10 plus years old, to repeat the testing with a new biopsy. But what I would be doing is calling into the lab that did that testing and saying, can you tell me anything more about my abnormal embryos? Could my abnormal embryos be mosaic? Could they also have some normal cells? Because when a laboratory tests your embryos, they don't need to hold on to the DNA from the embryos themselves, but they have all the data from testing it, and they'll have it for years to come. So they can actually oftentimes take another look, maybe run it through a new algorithm without even having another sample. So the lab is always the first stop shop if you want to get maybe an updated report or more information.
Okay. Are there, that is really, really helpful feedback and advice. Are there like, are there labs that are, as a patient, can you request like the type of report that you're getting back? And if so, is there a type of report that gives you more information?
It's usually, so I definitely have had many patients while working at a lab who would say, I want the raw data. And that's not something that really any lab provides. Maybe if you push enough, you could get it, but it's really extremely unlikely that it's ever going to help you as a patient or even as a doctor. It's not going to tell you anything. What's more important, it's not a different report, it's just the fine print below that table of your results, that fine print that explains what each result means, what they might not be sharing. So most labs have genetic counselors where you can have consults and go over your results in detail, or if your fertility clinic has a genetic counselor where you can ask all of these questions and ask things like, what don't I know to ask that I should be asking? Because you can't be an expert on this. I mean, it's something that's ever evolving, even like for me who works in this field and thinks about it every day, it's always changing. So yeah, I think you just getting in touch with the genetic counselor or the laboratory that ran the testing and kind of asking for a full run through of your results and then the limitations of the testing can be really helpful.
And then I want to kind of tie this back, you know, when we talk about like the testing that's coming back is sort of normal, abnormal, or that gray area. I want to tie this back to the beginning. When they're testing embryos in that way, that PGTA, how is that related to screening and looking for embryos maybe based on specific carrier screening that you might have? I know that's a different process that can also lead to some confusion.
Yeah, so there are multiple types of PGT, preimplantation genetic testing. So when you get a biopsy from an embryo, it could be sent off for a variety of things. By far the most common is what we're talking about, the PGTA, to look for chromosome imbalances. Because all of us, whether we have recurrent losses or not, we all have a risk anytime we conceive that baby or that pregnancy could have a chromosome error. It's just common. So PGTA, that's the common one. And then there's two other much less common PGT options. One is PGTM, preimplantation genetic testing for monogenic diseases. Those are those single gene conditions. If you've got a hereditary cancer gene that runs in your family, like BRCA1 or BRCA2, you can test embryos for it. If you find out on carrier screening that you and your sperm source are both carriers of the same disease, you could test embryos for that condition, for that disease. So that's PGTM. It's only eligible to us if we have a known genetic disease.
Yep.
And then the other one is PGT-SR, preimplantation genetic testing for structural rearrangements. That's testing where it's very similar to PGTA, but you're just zooming in a little bit closer for those patients who found out that on the karyotype, either the egg source or the sperm source did have a chromosome difference. So you can go and take a closer look at those chromosomes that are affected in the embryo samples. And again, it's really only eligible and only useful for people when a chromosome difference was identified with the egg source or sperm source. So those are the three I really think of: PGTA, PGTM, PGTSR. There's one that's kind of up and coming, which is testing for multifactorial diseases. It's very hotly debated. It's not widely utilized, but it will be probably in 5 or 10 years. You could go testing for things like diabetes, psychiatric conditions, and so forth. But it still needs a lot of work.
Yeah. Tell me, so I mean, to that question, tell me, where is the field of this going, in your opinion? As you know, as you're reading the research, like, and maybe I'll focus that a little bit as it relates to recurrent pregnancy loss. Where do you see this field of research going in genetics?
Oh man. Okay. Where I would like to see it going and what I'm most interested in is panels of genes that you can test an egg source and a sperm source for, and genes not like the ones on carrier screening that lead to, childhood onset or adult onset diseases, but genes that could increase the risk for a pregnancy loss, could cause fetal demise, or could cause losses around 6 weeks or 12 weeks. That's what I'm most interested in. And those panels do exist. They're just really not widely utilized, and they can be really expensive. Yeah. So I'm really curious and excited to see that happen, and for the idea of people being able to get an answer and saying, okay, IVF with testing for this cause that we've now found is maybe going to be our answer to significantly improve our chances. Yeah. I unfortunately don't think it's that close. I think it's more like 10 years from now that's going to be more widely available and useful. It's really just in infancy. Yeah.
Yeah, I know. It's if only we could stop time. Well, I'm watching the clock here, Katie, and I want to kind of bring it back to sort of general wrap up. So, you have lived through this, what this feels like, and you have a wealth of knowledge from this genetic standpoint. What advice do you have for people that are just kind of starting this process, have had some losses, are going through their diagnosis right now? What's your advice to them as they navigate the options of testing and treatments?
Mm-hmm. Of all the questions you sent in the outline, this is the one where I'm like, okay, the rest of that I could talk about in my sleep, but this is the one that, like, what is my best advice? And I came up with 2 things. Therapy. If you haven't done therapy yet, therapy. Like, recurrent losses, it just impacts literally every aspect of your life for weeks and weeks and months and years and years. Yes. And for some people, like, over a decade. And it's just like, it is put such a gray blinder on everything to go through miscarriages. Yeah. So therapy, and finding a therapist that that works for you and that understands loss, even if it's not their specialty. Like, mine was a man and didn't know that much about miscarriages, but he was wonderful and helped me so much. So therapy. And then the second thing is to be skeptical. You just need to be so skeptical when you're going through any diagnosis where there's still a lot of questions. Not just recurrent miscarriage, but anything where we still don't have a lot of answers and we don't understand a lot. And it's hard to be the expert on it. Like, I feel like I have as much expertise as almost possible, and still I didn't get an answer for why. For me, I didn't feel super confident or solid with the decisions I was making. But I think we just all need to be really skeptical, because there's so many supplements and different possible treatment options that have no evidence whatsoever. And if people want to go that route, I think more power to them, as long as they understand the risks and, like, what the chances are for that to work. But it's so hard, you know, any pregnancy could work and we don't know why or how for most of us. So we just have to be really skeptical of what we're buying and what we're, you know, what providers we're seeing.
Oh, I love that. Those are such good pieces of, those are brilliant. And I love, you know, because you know, it's like, for me, I love that you said skepticism, because it's like that it's different from, that just means like, know what you're doing, right? You can do something and it might not be totally proven, but you should know that, right? Like go in with your eyes wide open. I love that. That's great advice. What about advice to your colleagues or to doctors that are working in this space? Do you have any advice to other genetic counselors or you know, reproductive doctors that are working with recurrent pregnancy loss patients? What do you wish you could tell them?
Yeah, I wish, especially for my OBs, and I am a very probably annoying patient, which I think we all should be, and I've switched to many different OBs over the course of my treatment. But I think with OBs, I'm really disappointed at the lack of awareness that a lot of them had about what an impact recurrent losses have on somebody and like in all realms of their life. And I think sometimes they thought maybe they could talk to me like I'm like another provider in this space. And I'm like, oh, I'm not a provider right now. I am grieving and I'm so upset and frustrated and mad. And it's just really sad to see, especially I always felt really sad with my female providers, like just a lack of empathy and awareness of how impactful this is. Like not once did somebody tell me you should see a therapist. Have you thought about seeing a therapist? Do you think you need anxiety meds? Do you want to talk to somebody? Can I give you a referral? Like none of that ever happened. How could that not happen with like seeing probably a dozen different providers over the course of those years? It's mind boggling.
Yeah.
So just more awareness and empathy. And then I think the other thing is research, like please research us and help us find answers.
Yes.
Yeah, I think a lot of us would be willing participants in recurrent pregnancy research.
Yes. Katie, thank you so much. I'm so glad to have connected with you. And
Me too.
Anybody that is watching this on Katie's YouTube channel, she's got some YouTube videos that go really into detail of the results of a lot of these tests and really like with examples that
I share my own results. You can see all of my results.
They are so helpful. I've watched them all. So it's really, if you're like looking at a piece of paper and don't know how to understand it, please go watch her videos to learn more. Follow her on Instagram.
Thanks, Megan.
Subscribe to her YouTube channel. Yeah, no, thank you so much. This has been great.
Of course. Thank you.
I'm so sorry for your loss. I'm so sorry that.
No. Well, thank you. Yeah, thanks so much for saying that. I'm sorry for yours too. Like, why?
I know.
We'll never know.
Exactly. We'll keep working to figure out the whys. But
yeah.
Have a good rest of the evening. Thanks
for
watching. Okay. Bye.